Good afternoon. Thank you, Diabetes India, for inviting me here. It's strange that you see the US flag here, but I have been in India for first 30 years of my life in Mumbai and Pune, then moved to US. So, Jai Hind. So let's start with this topic is a little broad and it is nearly impossible to put all pathogenesis of all complications in 20 minutes. So I have made this talk as a springboard, broad. It will sound like more like a textbook chapter, but it will hopefully create a foundation for the next two talks that will be actually intervention targets and reducing the complications. So this broad picture will tell you the range of long-term complications related with uncontrolled diabetes mellitus. These arrows are not meant to be a cyclical direction, but basically they can happen at the same time or one individually at a time. And broadly, they are micro and macrovascular complications. So no doubt the initial stimulus is always high blood sugar. But when it starts the process in action, the cascade down the road may not be dependent on high blood sugar. There are multiple other pathways and intermediates that are involved. They get kicked into the action. So high blood sugar, very important word, persistent. Occasional high sugars are not so much, but if you have them for the years and years, so that's how we use the A1C. What it does is the cellular homeostasis is disrupted and it generates the oxidative stress with mitochondrial dysfunction. Then also there are induced inflammatory responses and then prothrombotic responses. There are multiple metabolic pathways and we'll go one by one in all of them, but as they're listed here, you will see these names. First, we'll go from the metabolic pathways, how they affect the individual organs, and then we'll go to the individual organs and look back at which metabolic pathways. So you will probably see these names again and again in a different settings. So this broadly explains most of the today's talk is oxidative stress on the left with mitochondrial oxidative pathways, and then glucose-related pathways, which are polyol, hexosamine, protein kinase C, and advanced glycation products. On the other side, the insulin resistance itself has some contribution to especially the macrovascular pathways to propagate the complications. So advanced glycation products, these are the non-enzymatic glycation of the proteins, and they go in the steps. In the beginning, you get the Skiff's bases, which are more or less reversible, and then you get the amidori products, which are more stable glycation products. But when they reach to the term advanced glycation products, by this time it is more or less irreversible. There is a vascular stiffness and also endothelial dysfunction. Now these bind to their receptors, they are called as RAG receptors, and that activates the subsequent inflammatory pathways. That leads to oxidative stress and the tissue damage. The second pathway is reactive oxygen species. Now, again, it is not totally independent of them. There is also interaction. So separately, reactive oxygen, when it comes out, it drives the both micro and macro complications. Basically, it starts with the sugar. It increases the oxidative reactive species, and mitochondrial dysfunction exacerbates it. This impairs our antioxidant defense. The other pathway is totally glucose dependent. It's polyol pathway, where excess glucose is shunted into that pathway, leading to sorbitol, and that accumulates. It causes the osmotic and oxidative stress in the cells. This is more pertinent to the neural and the retinal damages. The next pathway is the protein kinase C activation. The high blood sugar activates the isoforms, particularly beta, which are more damaging, and that affects the vascular permeability. Once the blood flow integrity is damaged, the products which are seeping out, they cause further pro-inflammatory cytokines and pro-thrombotic actions. This mechanism is useful in nephro, neuro, and atherosclerosis. The next pathway is inflammation. Now, this is once the damage has incited the injury, then the inflammation kicks in. And its chronic low-grade inflammation is a part of most of these complications. The cytokines are mentioned here. Now, this promotes endothelial dysfunction and insulin resistance, and it is contributing with both the pathways. Now, we'll come to the two major types, which is micro and macro. Micros are the small blood vessels, which are retina, kidneys, and nerves, and they are driven by either endothelial dysfunction or basement membrane thickening or both. And these are the link to those pathways that we mentioned before. Three major microvascular, one of them is retinopathy. Now here the high blood sugar induces the pericyte, the cells around the capillaries, and endothelial apoptosis. This leads to microaneurysm because of the weakening of the wall and then bleeding in the cell. Now from that point on, the injury further leads to subsequent mediators, which are VEGFs, that lead to neovascularization. And then on top of it, hypoxia. Now by this time, actually the hyperglycemia may not be the factor, but once this process sets in, it starts its own toll. Nephropathy, this starts with the thickening of the glomerular basement membrane and mesangial expansion. The podocytes, the cells inside the glomerulus, they get injured and they start leaking the albumin. And then the renin-angiotensin-aldosterone system activation exacerbates intraglomerular hypertension, and that further increases this leaking. This eventually progresses to reduced GFR and end-stage renal failure. In terms of neuropathy, the high blood sugars cause microvascular ischemia to the axons that leads to the axonal degeneration. And then there is also a demyelination that reduces the nerve conduction velocity. So this affects both sensory, autonomic, and the motor nerves. So basically, again, these long-term complications of the diabetes are generated with hyperglycemia. So that becomes the first target to reduce, and we all know control the sugars. But now once we know these mechanisms and the mediators leading to it, it can be a target for subsequent, we can say, therapeutic interventions. So in terms of macrovascular complications, the story is a little different. Now this affects the large blood vessels supplying the heart, brain, and limbs, which will respectively cause myocardial infarction, stroke, or peripheral vascular diseases. Here, the hyperglycemia is one of the components of the story. We require multiple risk factors, and the diabetes will contribute along with hypertension, cholesterol, and if you are a smoker. So those are the major risk factors, and other minor risk factors will combine together with hyperglycemia. So key feature here is the hyperinsulinemia is also one of the major factors in macrovascular complications. So if you know look at the history or the natural progression of the pre-diabetes into diabetes, the initial part you may not have the glucose increase, but you may have a hyperinsulinemia, which itself is a growth factor. So it is not surprising that a lot of patients who get diagnosed diabetes at the time of their first heart attack, because as opposed to the microvascular complications, the onset and the progression of macrovascular can start much earlier and continue to progress over the time. So insulin resistance, even at the pre-diabetes stage, reducing the insulin resistance with diet, exercise, and the weight loss, or sometimes pharmacotherapy, can help to reduce the people who have a very high risk for cardiovascular disease. So in atherosclerosis pathogenesis, the progression starts with endothelial dysfunction, and LDL oxidation is more favored in the uncontrolled type 2 diabetes mellitus also. Now, as I said, insulin resistance by itself, high insulin can be a growth factor, but it also induces hypertension. Those two are kind of interchangeable each other, that insulin resistance and hypertension go together because they feed on each other. Now, as we mentioned, the chronic inflammation induced by the previously mentioned oxidative and other damages will set a stage for the plaque formation, which is again exacerbated by the cholesterol and oxidized LDL. On top of it, some of the metabolic pathways in complication induce thrombotic factors. So this is like a whole enchilada of all storms set together to produce the atherosclerosis. So again, as we already talked so many times in diabetic forums, that having diabetes itself is the highest cardiovascular risk factor, as if you already have a heart disease. And that forms the basis here, that through the sugar, high insulin, and the subsequent metabolic pathways, you are going to get most of these complications. As I said, there is an impaired vasodilatation also. And the last, I think I'm going to go a little quicker, so I'm going to finish before time. But in addition to these standard pathways that were mentioned in our standard textbooks, this is a little bit newer, again, mechanism as well as the target for treatment, is how our gut microbiome affects diabetes complications. So we already know that altered gut microbiome affects insulin sensitivity, which means is associated with more diabetes, but it also has association with systemic inflammation, which means now it is contributing to the complication on both sides. And this was not there when I did my endocrine for the first time in 90s. Also, there is an increased gut permeability of metabolic endotoxins. So bacteria there are, in addition to have some activity which will cause the substances to pass through the gut, which are not supposed to be, and they will eventually work as endotoxins. So as I said, this is going to be an emerging target for the therapeutic intervention. I tried to make it as simple, as sweet, as small as possible.